Hey, everybody. Welcome back to the Pre-Hospital Paradigm Podcast. This is Scott Wildenheim. I got the crew back here for the recap of Dr. Singer's toxicology. We got Ray Pace over on my right side here. I got Caleb Ferroni sitting across from me there. And Dr. Singer, thanks for coming back. I know you rearranged your schedule to be here, which is much appreciated. You, I think, so far have won the award of the most voluminous episode. But it was just packed full of information. And for those of you that don't know or are tuning in, hopefully you're tuning in on Facebook because we just got our Facebook. We were in Facebook jail. So apparently we were impersonating university hospitals. So we were shut down, and it took us a long time to prove that, in fact, we are in fact university hospitals. I don't know that we ever actually proved that we were university, but whatever we were doing, they decided that they were going to let us have our Facebook back. So hopefully you're tuning in on Facebook, and if you have questions for us, the team, Dr. Singer, please throw that in the comments below, and we'll see them up here. And since I have to do some cleanup work here from last time. So we promised grab bags for anybody that gave us questions last time. And then our Facebook was promptly shut down. So
we'll make it up.
I'm not ignoring you. I just need to. We just got access back, so we need to do some cleanup. And again, if anybody texts in either YouTube or Facebook, because we're live on both, then we will. And I don't have my grab bag put together, but we'll give you a UH grab bag of all kinds of UH swag. And no, there's no gold bars, and no, there's no free medical care for life. But nevertheless, that we'll get back to that. That's, I guess, our fault for upsetting the bots at Facebook, and now that we have access back to that, we'll get those bags out to you here in the next week or so. Hey, thanks for coming back. And so for those who maybe have not seen the last couple episodes because of our Facebook outage, so I guess let me do my shameless plug here. Go subscribe and follow us on YouTube. That way, next time this happens on Facebook, you will subsequently still get all of our content. But if you haven't watched your episodes, you were really instrumental in bringing some major change to the 23 protocol. And that was really three big buckets of things, right? There was toxicology, and toxicology, and that blended over a little bit into hyperkalemia as well. And then the other big thing was the change in our rapid sequence intubation. The big bucket of stuff, of course, is the tox stuff. So before we dive back into this, you've told me this offline before, but why the interest in this? And I think I made the comment in the original recording that even some of your physician peers, when they were looking at the CE that you did, they were like, "Oh, I got to learn all this all over again." Where's your interest in tox and all this come from?
Yeah, so where I did my training at UPMC in Pittsburgh, we had a very good toxicology program that garnered an interest for that. Yeah. And at least in the field, we have a lot of the tools and the drugs that readily can be used to treat toxicological emergencies. And so there's no reason to wait till we get to the hospital when we can aggressively resuscitate these patients in the field, which is why I wanted to enhance the protocol to allow our providers to practice up to their license and do all those great things in the field.
The thing that I find, so as far as treatment paradigms, of course, we've got the medications to offset some of those things, but really that entire cardiotox, we'll talk in just a second about how we broke that protocol up a little bit, but the whole cardiotoxic protocol is all predicated on the one thing we as paramedics, anyway, should be super, super good at, which is EKG recognition, right? It's stuff you're already doing, right? Yeah, you're not asking me to do anything new. But and I don't know about you guys, but oftentimes I would certainly just get in a rut, just throw the EKG on. What am I looking for? STEMI or no STEMI? And okay, that's good. And then send we wouldn't really take the time to think about QT intervals or various other things.
Peak T waves.
Peak T wave.
Looking at all those other portions of the EKG, not just STEMI, not STEMI, and I think your lecture really made us dive deeper into that.
Certainly me, right?
Oh, 100%. Just like the physicians had to prepare to teach it, we had to prepare to teach it a lot. I know it's just not, we all excel at certain areas. That's not an area I excel at.
Right,
So
right.
it was a lot of learning before you taught, and I think that makes us better. And I think you're a huge asset in this department to really improve this protocol and bring it around. But yeah, the EKG thing is huge. We're not just running a 12 lead looking, do I have a STEMI or no STEMI? It's, if I have peak T waves, well then how big are they, right? How, we're starting to get into per se guesstimate what are their levels.
Right.
And at what point is treatment going to be appropriate? What's our first line, second line, third line, and continue down. And we kind of dove into that dialysis protocol where we get into bicarb and calcium and all these different features. And you really helped us, I think, dive even deeper into, beta blocker overdoses, calcium channel blocker overdoses. I think all those things really made a well-rounded protocol for us to just advance.
And it's amazingly user-friendly as well. If
Yes.
you're looking at the protocol book, and you can, if you're not with university hospitals, download our protocol. It's not a secret. UHEMS.org, go to protocols, download the most current, and you'll see what we're looking at. 34.5 is toxics, ingestion, exposure, overdose, cardiotoxic medications, and it's broken down so nicely with little snippets of EKGs even, and it makes it so user-friendly.
And these columns are not isolated. I mean, our patients who overdose frequently don't know what they overdosed on or are unconscious and can't tell you. And so a patient may have taken something in all 4 of these categories or with the other protocol, all 8 of those categories, and you may have to treat them along every single one simultaneously.
I think you've used the vernacular earlier. Sometimes you just got to throw the kitchen sink at them. Right?
And these are the patients to do that.
Yeah, you dump the box, drug box out on the floor and start sifting through it. We can use this. We can use this. We can use this. But yeah, there's multiple ingestion. That's to your point. They have a pill party. They reach in, grab a handful of who knows what. Right.
They rarely take one thing. It's almost always polysubstance use.
Sure.
Yeah, and even looking, this is so much easier now to break down common beta blockers, common calcium channel. It just goes through all these more common medications on the next page. It's just been great. It's great for teaching too.
So we have to give a plug. We have to give a shout out to Dominic Silvestro. So he was the one that suggested. It's like, why can't we put the EKGs in there? I'm like, and I was almost embarrassed when he said it. It's like,
I should have thought of that. And you hate bringing that up too.
That's
but
pretty. No. It's spot on. It was a fantastic ad, and then basically we just robbed it out of his CE presentation, and we're like, yeah, if it's good enough for the CE presentation, I sure as hell am not going to remember it at 2:00 in the morning, and so we just grabbed it and threw it right in there, and I think that's. I'm very happy with the way that page in particular, because all of that previously was smashed into one big tox page, and it served, I think, nothing well. Right? It served a little bit of a few things, but it didn't do it tremendously well. So that's why we split off. So let's talk about the changes on the actual tox page, because there's a tox page and then there's a cardiotox page, and the cardiotox page is all of the substances, mostly antiarrhythmics, right? That people are very, very commonly on.
Yes.
But before we get to that, on the tox page, which used to have all of that kind of smashed in the middle, and then it was organophosphates off on the side, and then it was, the narcotic overdose off on the left side. The what are we? Oh, nice. We're becoming high tech here. We're getting grease.
Live updates.
We're getting live updates. Hold on a second. I get my ear wig in, so he can just tell us what's up. But
no, the new format is beautiful. It's all laid out in a much broke down fashion.
Let's talk about those 2 ads to the middle column there, because that was mostly all him. And again, I'm kind of embarrassed that the protocol team didn't come up with specifically the sympathomimetic overdose. I mean,
Wonder who that would be.
Who some guy. There's who hasn't been on a cocaine, a patient that's
Any stimulant. I mean,
correct.
even too much caffeine could stimulate something like this.
Caffeine, meth, right? And it's now I think we by default and good clinical knowledge, got to appropriate treatments for him, but it wasn't well spelled out. So let's start with the sympathomimetics. I mean,
So the key to these people is they have a sympathetic surge. They're revved up. They're hot. They are tachycardic. They're hypertensive. They can get vasospasm and actually get a STEMI pattern on an
Right.
EKG. And everything we're trying to do is to bring their body down. If they're hyperthermic, we want to cool them, just like our hyperthermia protocol that we just created. And then we want to sedate them with benzodiazepines. That is the drug of choice for any overdose. Is if they are too revved up, we want to give them benzos. And then if you think they need more benzos, call med control and request more benzos, because really we just want to keep on giving them benzos over and over again.
You're making the point I wanted to make here, which is what's documented in there likely to be enough?
It may not be. I mean,
Yeah.
you may give them a dose of Versed, which is probably the drug of choice here, because you can give it IM, IN, IV, however you want to give it. But if it's not good enough, this is a trigger to call med control. Sometimes people who call med control are some of the most knowledgeable providers, because
Correct.
they know when the protocol is insufficient and they know when they need to call for those additional orders. We don't want you to just go rogue and do them. If you call me and say, hey, the protocol ain't cutting it, I think I need this, I will be like, you're exactly right. You have orders to do as much as you need in this situation. Thank you for calling.
My tagline is, you're allowed to be smarter than the protocol.
Exactly.
We would prefer you be smarter
Yeah.
than the protocol, right? But that's it. It sounds like, from the doctor's perspective, from the physician's perspective, you really enjoy the people that are that do know more and are asking to
Right.
expand that beyond.
The forward thinkers, the smarter than the cookbook thinkers. Any Italian cook will tell you that if the sauce calls for a pinch of salt, you get 4.
This is a base level of knowledge, right?
Exactly.
So
And I think the other thing too that is a good reminder to squads, because we get this question in CE all the time. Well, my ambulance carries 2 drug boxes, right? So if I exhaust that first NARC box and I still think my patient needs more benzos, can I call online med command? And I think that's been a huge encouragement from all the instructors that are teaching CE. And it's like, yeah, if you have that forward thinker that's played that algorithm out already, because they are intelligent, they're making good decisions, but I don't think this is enough. I think I need more, right? Because I do want to calm that patient down, because the side effects are extremely harmful to that patient.
People can acutely die of a sympathomimetic overdose before they get to the hospital, and that's why these protocols are so important, because we are not ambulance drivers. We are pre-hospital providers.
Mm-hmm.
We want to be aggressive, and if you need to request another unit to rendezvous with you just to get their drug box, if you have a prolonged transport, that is absolutely a reasonable thing to do.
I want to piggyback off that just a little bit. If you're calling med control, ask for everything you might need.
Exactly.
You can your doc can give you an order beyond just the next thing.
Yep.
Right.
If this happens, you can do this.
Right.
And a good
Yes.
med control physician will do that, but sometimes we're not thinking ahead as much as you are, and you could trigger us to give you those
Yeah.
additional orders. If you only need to call once but get 8 orders, that saves you time.
And I think I think that's a great thing. I think it's a good teaching point. I think the instructors deliver that well, and I think we've really opened the door up from the past. And this is my personal opinion: is it's like you never wanted to call med control,
It was,
right? When we
yeah.
started,
There's
or
a
am I
stigma.
off there? It was always like, I don't want to call because then I seem incompetent. It's like, no, you're not. Like, make that connection, have the conversation with the physician, be a forward thinker, and then say, hey, if I do this and this doesn't work, yes, discuss your next steps. I think that's a great thing, and I think it's a great point to
And
elaborate
from
on.
an ER physician side, I mean, how often are you calling for consults of other ER physicians and
Oh, yes.
doctors and surgeons, and do you ever feel incompetent in your skills because you're doing that?
No, I mean,
So-
knowing your limits is one thing, which is why it's reasonable to call. But it's also if you know the limits of the protocol, and so if you're calling for assistance, sometimes you're calling with the specific order. Like, I think I need additional Versed. I need an order for it, and I'll just be like, "Yep, that's
You're
exactly
right.
what you
Yeah.
need. You're right.
Yeah.
Well done."
The other big change on there, and this was kind of eye-opening for me, was the aspirin overdose,
Yes.
right? And we talked about just the amount of, if the patient is tachypnic because they're acidotic, we have to be aggressive with the sodium bicarb.
That's where the damage is already starting to happen.
Correct.
And any patient where you're worried about aspirin, it's very reasonable to be aggressive with the bicarb. If you give bicarb to someone who doesn't need it in this situation, you're not going to hurt them. They have normal kidneys, normal lungs, they'll be fine. But if you fail to do it, that's where harm can happen, and we want to be aggressive.
The other part of this is needing to take the airway. So the metabolic acidosis patient,
These are the scariest intubations.
I would say,
My-
and that's even coming from a physician standpoint, not even an out-of-hospital standpoint, or the metabolic acidosis cases. They're the ones that are going to die on you, right?
Yeah, and the issue is we always worry about oxygenation, but these patients don't have oxygenation issues. You're going to get the tube in with a SAT of 100% every time. But even if you are the world's fastest intubator and got a tube in under 10 seconds, which I can't think of anyone who could paralyze somebody, intubate them, blow up a balloon, and start bagging within 10 seconds.
That guy right there.
Maybe if somebody can do that. But that 10 seconds of apnea leads to a rapid rise in CO2, rapid fall in pH, and that just can push patients over the edge and kill them. And that's why the scariest patients are not the hypoxic, obese patients. It's these metabolic acidosis patients, and aspirin is one of those.
I think the other point there is what do we want to see, just from a recap standpoint, is what do we want to see for a capnography on these patients?
Yeah, we want it a little bit low,
Right,
and so that's because a normal response to a metabolic acidosis is to breathe fast, that small breathing we see with DKA, and blow off that CO2. And if they're not doing that, and we think that they are acidotic from aspirin, that means their body is not doing enough. Aspirin's going into the brain, and it's going to kill them, and that's what we want to prevent.
And if I have to take their airway, so let's say when I got the patient's side, put the Capno on it, and it's 22, expected because they have a respiratory rate of 45. Now during transport, I see that 26, 28, 30, 32. Where do I draw the line? Where's the time to say I have to take this airway? Because we want them to breathe on their own.
When it's starting to climb, because by that point they are proving one of two things: either their brain is not telling them to breathe fast enough, or they are just tiring out, because it's just hard to breathe that fast and hard. You just get tired. And so if you're starting to fail, we have to fix that situation. And when we do get the tube, we need to ventilate them at the rate they were ventilating themselves before they started to collapse. So the goal is to ventilate them to an end tidal of 22. They've told you what they need and what they can maximally do, so we're going to match that, and that's the goal.
This was my scenario in medic school last weekend. It was actually DKA, but it's metabolic acidosis. And we were going this exact same talking point, right? And if we have to take their airway, what if I've already given bicarb early on, and now 20 minutes later I got to take their airway?
I would give them an additional dose of bicarb, and that's what the protocol says, is to get right before you're going to push meds or sedate them or try to take their airway, give them that extra push of bicarb and an additional 1 to 2 units, and maybe that'll buy you time. You still got to be the fastest intubation of your life. This is not for the trainee. This is for the most experienced person in the room.
Give me the EKG changes with the aspirin and DIG. There we go. So they're seeing they're seeing the question on the live stream as well. So the question there is, what are some EKG changes that we can expect to see with ingestion of toxic levels of aspirin and DIG?
So aspirin, you won't see anything. That's you don't know if the patient may have overdosed on something else. It's often not just aspirin, which is why EKG is a piece of paper. It's harmless, it's cheap, and it tells us the really bad stuff we have to address. So if anything ever says to you, maybe I should get an EKG, the answer is yes, always yes. You're never gonna hurt someone, but if you don't get it, you may miss something. So not gonna see anything there. But with digoxin, you may see signs of hyperkalemia, and if somebody overdosed on digoxin on the acute setting, and you see changes consistent with hyperkalemia, there's a near 100% chance they're going to die, no matter what you do. So hopefully you do not see any of that, because that's really bad news if that's the case.
Really bringing this in with positivity now.
Yeah, so those are the two you may not see anything, and if you do, this is really, really bad. Or they took multiple things, right? You may see QRS prolongation because they took something else that's doing that.
And then I think we already touched on, let's see, what are the merits of sodium bicarbonate and acidosis secondary to overdose? I think we pretty much hit that already, specifically from the metabolic standpoint.
Yeah,
right?
so it's mostly we're giving sodium bicarb for the sodium component with most of the overdoses, but in acidosis, it's really just from aspirin that it's effective. If you have someone with a non-specific metabolic acidosis, maybe from lactate buildup or something else, sodium bicarb doesn't do as much. But from aspirin, because it's kind of a slightly different, it is more effective.
Let me state that another way, that the only time in protocol as we have it currently written that we're using sodium bicarbonate for the bicarbonate component of that to modify pH is in aspirin overdose. Every other time we use it, hyperkalemia, sodium channel blocker overdose, we're using it because it's the biggest dose of sodium we have available.
It's the equivalent. It's the equivalent of hypertonic saline in terms of the concentration of it.
John, was that about it from those two things? Here we go. How about Tylenol? Fantastic. Tylenol, and let's expand that just a little bit. Tylenol or ibuprofen overdoses in the field. So let's split that into two questions.
So
they are sympathetic and they are not.
So I will do the Motrin or ibuprofen one first. So any NSAID, with the exception of aspirin, which is technically an NSAID, but it's a different form of it, really is not that toxic unless you take mega doses. Like I don't even know how much, but it's a ton. And so for the vast majority of overdoses with Motrin, naproxen, any of the NSAIDs that people regularly take, there's not much we're worried about other than the fact that they just tried to hurt themselves and we need to transport them for a psychiatric evaluation.
Sure.
Unless they took mega doses, but they're going to look sick for a multitude of reasons. And then Tylenol, most of the overdoses are not toxic for like 6 or so hours after you took the Tylenol. And so our job is just to bring them to the hospital so we can measure a 4-hour level after that ingestion. And if that 4-hour level is below a cut point, nothing to do, they're 100% fine. If it's above a cut point, there is a very good antidote that the hospital gives that you give over, I think it's about 24 hours for the full dose, and it basically prevents the liver damage that can occur. But if somebody takes mega doses of Tylenol, it can cause metabolic acidosis and cause major hemodynamic changes in the field, but you're just going to treat that like any other hemodynamically unstable patient. We're not going to treat it differently because they took Tylenol.
Supportive care,
Exactly.
essentially treat them by a shock protocol.
Yeah, if they need fluids, give them fluids. If they need push dose, give them push dose, whatever they need.
Fantastic.
Good question.
Yeah, no, it's a really good question. I think that's it for those two. I think we can run into some of the cardiotox stuff now.
Sure.
I think that was because we're going to get to those questions right there because those are going to come up in a minute. You can hold that question for just a minute, but
Sorry.
what's up? Go. They know you're standing back there. It's not like Dr. Hill is behind the.
Darren's funny.
He's the puppet master. He's just telling us what we're supposed to say here. So then we split all that. We talked about that already. We split off the cardiotoxic medications, and these are medications that people are frequently on, right?
Yes.
So let's talk about some of the more frequent medications that like everybody's on that's on that page.
The beta blockers are probably the most common.
Ubiquitous. Yeah.
In terms of the beta blockers, it's just a plug is just to be aware that it's going to blunt people's tachycardia. So in trauma or any type of reason for the patient to be in shock, don't just rely on heart rate because they may not be able to mount that tachycardia, and despite bleeding to death or something like that. So, but if you overdo it, you can get bradycardia, shock, and these patients can have blood pressures of 60 over palp and have a heart rate of 30, and they are in profound shock from that. And really what the protocol says is throw everything at them, but it orders it in the things that are most likely to work. And so you basically throw one thing. If it works, great. If it doesn't, you just keep on going down the list. And there's a very solid chance that you will throw that whole thing at them and it will not work. It just can happen.
Give us that transcutaneous pacing question. So why doesn't transcutaneous pacing work in beta blocker overdoses? Is the
So
question.
it can work. It's just not something we lead with because the issue isn't heart block because the AV node is out, which is often why we're using transcutaneous pacing. It's just that the cardiac myocytes are just not conducting or doing the right things because every heart cell is being affected by the beta blocker. Versus with transcutaneous pacing, you just lost the AV node, you're in heart block, but the ventricle myocytes are functioning normally if they get that electrical impulse. So this is different. It might work. It's just like everything else, unlikely to do so.
And that should not preclude you from doing the rest of the.
Right. You should. I mean, pacing is allowed in our protocol for this, and so I would encourage you to try it. And if it works, fantastic. Just do not rely on it like you would for heart block. For our standard heart block, we want you to go to transcutaneous pacing early because atropine does not really work, but pacing will. But this, you got to throw the whole thing at them.
My other pet peeve here is pacing works. We get electrical mechanical capture because that's what AHA told us to say, and it actually happens. But the patient's still hypotensive. Can I still use all the meds?
Absolutely.
Yeah.
Yeah, the whole thing. And remember, so you may get the
He
heart rate
knows
up.
that's my pet peeve.
Yeah, you may get the heart rate up, which is fantastic, but the beta blockers affect the heart's ability to contract with enough strength. It's a negative inotrope, and so the heart rate now is 70, 80, which is great, but if the heart still just won't contract very well, you still run into the same issues.
And we're not doing atropine for LOL drugs?
So you can. It's just probably the least likely to work out of everything. You're probably going to get the most bang for your buck with push dose epi for beta blockers, to be perfectly honest.
He's fussed at me a bunch about that. He goes, almost like, do I have to put it in the protocol? He's like, yes, you have to put it in the protocol.
It's just
It might work. It might do something.
Might do
kitchen
something.
sink mantra.
Indeed.
Try it.
And I was just like, okay, I will. Everything else is so good.
But don't inveigle these patients out.
No. And the other thing is, what it can get to with these patients is they may end up getting transferred to one of the main hub hospitals for ECMO, for heart and lung bypass, because there's literally nothing we can do for this human being other than get a machine to do the heart's job until the body metabolizes the drug away, which stinks for some of the calcium channel blockers, which are extended release. So these things could last for 24, 48 hours. And so that's one of the things that we worry about. And you shouldn't go straight to one of these centers because they need all the supportive care that the local hospital can initiate. But you may get called for an IFT to get this person downtown later.
I think another thing that's a good talking point is you think LOL beta blockers, you think elderly, but that's not the case. You have 20-year-olds who are prescribed a metoprolol or something for PVCs.
Yeah.
So,
and then something to think about is propranolol is the first line agent for social anxiety disorder.
Anxieties,
And so that drug, if somebody has social anxiety and then gets suicidal and has easy access to propranolol, they may take it, which propranolol is the worst out of all these because not only is it a beta blocker, but it's a sodium channel poison, so it can really wreak havoc on your heart.
What's the next column there? Is sodium or
sodium channel.
is sodium
Yep.
channel?
Tricyclates.
So TCAs have historically been
They're the poster child for
I
sodium
like
channel
that. Yeah,
poison.
that's historically been the focus specific. I remember going through paramedic school.
Oh,
It
it's
was
That's a big focus. Like, we have to talk about this section.
the
about,
amitriptyline overdose.
right. And it's just
How many registry skills have we done with amitriptyline? So
Almost
every one.
Exactly right.
And we don't use these drugs as much since the
Correct,
SSRIs
yeah.
came out because the SSRIs are so much safer, but the TCAs are better. They're more effective. And so if you fail the more safe drugs in patients who are high risk to overdose, we may have to literally be giving them a potentially loaded gun
Correct.
and saying, hey, hopefully this works. And sometimes it doesn't, and they may overdose.
The point that I wanted to make in that with the sodium channel blockers, there's a very common drug, and I know that I've been on these overdoses before that acts in big doses, like a sodium channel blocker, and that's Benadryl.
Exactly.
Yeah.
That's the most common sodium channel poison you're going to see. And so when I hear a Benadryl overdose is coming in, that gets my heart beating fast because this person could have only taken a little bit and be a little bit kooky or a little bit drowsy, or they could be running the
Profound
gambit
shock
for
and-
everything and needing tons of resuscitation.
Yeah. And how do we pick these? How do we pick out these patients that have sodium channel blockade? What's that going to look like on our EKG? So we got to take us one step back because we didn't talk about the EKG and beta blocker overdose.
So beta
That's just
blocker
going to be slow.
is just going to be either a complete heart block or a sinus bradycardia. And that's the same thing for calcium channel blockers, which we'll get to, but it's going to just be some slow rhythm.
Yeah. And then the sodium. The sodium channels, how's that going to manifest itself
It's
on my EKG?
any unexplained QRS widening. So if you have a young patient who should theoretically have a normal heart and not have widened QRS, if they may have overdosed and their QRS is greater than 120, I would assume it is sodium channel poison until proven otherwise and treat it accordingly.
which is 3 of the smaller EKG boxes.
And you could use the number, like we always say, don't use the interpretation. I would say don't use what the computer is saying is going on, but you can use the interval, heart rate, QTC. Those are pretty accurate.
The data, yeah.
You should confirm that it looks similar, and if it does, you can probably take those numbers to the bank. So if the QRS is greater than 120 or 3 boxes, then I would start to worry worry that this could be at play.
And what am I worried about? That drawing out, that getting wider and wider? Why would that worry me?
It's a sign that the sodium channels are not functioning, and eventually you can go into ventricular dysrhythmias. When you get above 160, you could suddenly go into VTach, VFib, or asystole.
Yeah.
All are not very good rhythms to go into.
Indeed not. No, right.
And so for that reason, we
Suboptimal,
want to
yeah.
be aggressive. And then by giving them sodium, you are basically forcing those channels to work a little bit better by overloading them. And so that's why we basically are giving them what they're having blocked.
I think that's an easy way to remember that too. Is like, not everybody's going to get in the weeds as we are right now. And
Right.
how do you remember it? And I think you explained it really well in your lectures. You know, if it's a blocker, I'm giving that drug because it's currently being blocked. And I think
Exactly.
that's just a general easy way to try to get everybody to digest it. You know, look at these.
Overrun the blockade.
Yeah,
Exactly.
100%. That's all you're trying to look at. And I also agree with your point about the monitor. You know, I'm not a really big guy for read the top of it. What does it say? Because sometimes you'll print it off, and if you have Artifact, it gives you a novel. You know, but one of the things that the monitor's really good at is it's judging time. It's very accurate for that. Very trustworthy to use the, you know, what is the width of the QRS? I will just look at that. It's not, most of the times it's not worth measuring it again. It's accurate. Right.
And you should just look to say, oh, yeah, that kind of correlates with the number. It's not
It's a checks and
grossly off
balances.
or
Yeah,
something.
checks and balances way.
Yeah.
Right. And
to look at
we
it.
had a lot of people freak out about that when we mentioned, prolonged QT syndrome for ondansetron, because we give ondansetron to everybody. It's like,
Yes.
it's easy. Look at the boxes. Does it say? Does it confirm that you're that far away? Because that's a big distance. But yeah, look at that for your confirmations. It's so easy to see.
And then the protocol itself specifically has us look at AVR. So you're looking for just in general a prolonged QRS, but we call it a terminal R wave in AVR, which is the lead we don't look at all for ischemia. But if you have this big coved shape, it's kind of hard to describe, R wave that you just need to look at a picture of and just kind of get it in your head. But if you see that, that is sodium channel poison until proven otherwise. And the best part about this is if you treat it with sodium, giving them sodium bicarb, you will watch it narrow in front of your eyes. So you can keep them on the EKG and get it and print it out as it's going, or you just watch it narrow on the monitor, which is super satisfying because you did two things. You confirmed that you were right,
Yes.
and you saved that patient's life.
And you
So
watched
it's
it
great.
live, so it's
Exactly.
even better, right? And I think the other thing, too, to your point, and I know I keep adding very minor points to what you're saying, is, keep that patient on the monitor the entire time. If you hooked them up to a 4
Absolutely.
lead and you put your 12 lead on, we teach this religiously, continue to keep that patient on the 12 lead for your whole trip to the hospital, because if it senses a change, don't hold me to this, but I want to say Stryker's product or our LifePak 15s, I think it's 2
It'll
minutes.
spit
If
up.
it sees it consistently for 2 minutes, that is going to run another 12 lead automatically. So you're going to see the live change, but in the background while you're doing other things, maybe starting another IV or working on the airway or something like that, it's going to continuously just feed you 12 lead EKGs to show you the cardiac changes that are occurring. So, and I think that's very good to import to your chart too.
And these are not the cases to disconnect them when you pull in the ambulance bay. Leave the monitor.
Yes.
This is someone to put pads on because if they're going to go into VTach or VFib, like it's much easier to click a button and shock them than to scramble to throw pads on someone who just suddenly went into cardiac arrest.
So we just discussed if if that was true and we fixed it, we see those QRSs close up. How about the converse? I think it's sodium channel, or I think it's sodium in nature. I push an amp of bicarb and nothing happens. Have I hurt the patient?
You have not hurt that patient.
Yeah.
And one of two things may be true. They may have not taken a sodium channel poison, and maybe their QRS has always been long because maybe something happened that we don't know about. Or two, they just need more sodium, and you may just not have enough. Because when I hear about these patients, I call the pharmacy and I say, just give me all the sodium bicarb you got, because I'm going to keep on pushing it until it works.
And just bring a pallet up.
Exactly.
And I think it's funny because we always like say that, and then I incorporated that into your lecture the one time because we were talking about dialysis patients, and they're like, "Oh, we use so much calcium and so much bicarb in these patients," and I was like, "No, for real, I saw it. Like they were bringing the bicarb down in the shrink wrap brick.
Yeah.
One person's carrying a brick of calcium and the other one's carrying a brick of bicarb down to the ER, and there's just boxes everywhere, and I'm like, we should have taken a picture of that and been like, this is what it really looks like, because it's like." Yeah, I don't want to say you don't believe it until you see it, but it really drives it home to say it takes that much, right? We only have 2 amps of bicarb in that drug box,
Right.
So utilize your resources. Whether it's another drug box on your unit, maybe intercept a unit. Think outside the box like that.
Absolutely.
I recall now we're going to same concept, different agent, different poisoning, but in organophosphate poisonings, we don't have enough atropine.
No.
And I recall a picture of, I think it was Southern Ohio somewhere, but they took a picture after the patient, finally, and there was a tray sitting on a desk, and there was a, average sized nurse standing behind it, and there was just a mound of empty vials of atropine, right? And it's just like, oh, they really mean we don't have enough.
Oh, yeah.
If you have a significant organophosphate poisoning, like we may be giving hundreds of milligrams of atropine. I mean, think about it. We're giving 0.5 on a dose, but we may just be giving, we go 2, 4, 8, 16, 32, just keep on doubling the dose until we stabilize them. It's crazy.
That's crazy.
The volume just amazes me. How the quantity and the volume is insane.
So that, I guess that takes us to our
Calcium channel blockers.
our CCBs, yep.
So these are going to be very similar to our beta blockers, except we are going to give calcium earlier in the process. So if you look, calcium is listed first for the calcium channel blocker, and it is listed somewhere in the beta blocker line.
Yeah.
The reason we give it to beta blockers is there's some overlap with the cellular mechanisms of how these both function, which is why they can work. And then the other thing is calcium is an inotrope. If you give any human being a push of calcium chloride, their blood pressure is going to go up. Short-lived, but it does happen. So that's kind of why when we say throw the kitchen sink, we are literally reaching into our drug box and giving them everything that could theoretically work.
This looks fun. This looks
Exactly.
fun.
And this is going to look more like a bradycardia. So again, push dose epi might be warranted.
Absolutely.
You might want to try the atropine into the line, but
It's not going to hurt this patient.
Wait,
You just don't want to lead
what
with
do we all
it.
just look at
And
Scott?
he glances at me like, yeah, I said that.
But I think what Scott didn't want to put it in initially because he didn't want us to lead with it because it's very easy to use it as a crutch and say, oh, at bradycardia, let's give atropine,
Correct.
which I'm okay with giving atropine here, but it should not trump the other stuff that are first. Like follow the order because those things will be more effective.
Yeah, my frustration there, of course, is how we're taught in AHA, which,
Consider.
trial atropine first, and then if it
yeah.
doesn't work, failed over to other things, right? And I QA them once, twice a year. It's, my paramedic instructor, AHA told me, atropine raises heart rate, and I gave it, nothing happened. So what I do? I gave some more, and that didn't work. I gave some more, and I just didn't want to get in that
Right.
cyclic
Spiral,
loop, right? You give it doesn't work, move on.
I mean, if
100%.
you have an abundance of resources, like I have some crews that their first responding fire department is ALS, so they have maybe 4 medics on scene, which is amazing.
Spectacular.
If you can do all 4 of these things simultaneously, absolutely give atropine because you can do it all. But
Why
if
not,
you're the
right?
one medic who has to do all this yourself with maybe one EMT to help you, you just want to do the things that are more effective first because you have limited time and limited hands.
And that basically sums that up. Potassium channel blockers.
So this is brand new for this was never addressed in previous iterations of the protocol, and this was really again I think we probably just didn't quite know what and how to document it, but you brought that to our attention, and there's actually things we can affect pre-hospitally
Absolutely.
with the potassium channel blockers. But this is the one case where we're not going to give the thing to overcome the blockade, right?
That's the lethal injection
That
in
is
term of potassium.
It is literally the lethal injection,
Exactly.
right? It's a dose of potassium, and we're not giving that to you. Okay.
Yeah, in this case, when you're when you have QTC prolongation, which is most likely from poisoned potassium channels in your heart, the concern is that you're going to suddenly go into torsades, and that's what we worry about. And so what we're doing is we're trying to decrease the risk of torsades and then prepare for torsades if it were to happen. So this is the person who I'd put pads on because, as I said before, if you suddenly need to shock them, it's much easier to click a button than scramble to put pads on. And then we're going to give magnesium, which does not shorten the QT. It'll stay long, but what it does is it decreases the likelihood of a PVC and suddenly going into torsades from that PVC. And so that's what we're doing is decreasing the rate of torsades.
And it should be easy to remember,
Safety
too. We're giving mag sulfate, every medic student knows, for torsades the point. So
Right.
After we shock them out
After
of it.
we
Because
shock them
the
out
key
of it.
is electricity first, magnesium second.
Yep. Medicine before medicine.
Absolutely.
All right. Now I think we've got some questions specific to those 4 columns. So let's run through them here. I'll pretend like I can see that. That did not help. Let's see. We're talking about TCP. Let's see here. Decide. We'll get to that in a minute. Keep going down. Keep going down. Indications. Sedating patients. Keep going. Keep going.
hello, community EMS and Russell Fire.
Let's see here.
Yeah.
Let's talk about the beta blocker overdose there. What's that say? For known beta blocker overdose. in severe case. Thoughts on getting a helicopter to the scene if they might need ECMO?
So the majority of these, I don't think end up needing ECMO, but some will, and at least the almost every community hospital has the additional pressors and supportive measures that are necessary. I don't think I would recommend calling a helicopter in the field. This is definitely someone I'd start supportive care and then expedite transport, because they may need 3 or 4 different pressors that all these hospitals have. It's a reasonable thought, especially if you are really, really rural and maybe only have a true freestanding ED nearby. That would be a reason to call for a helicopter. But the vast majority of our catchment areas that we're providing medical direction to or that are using our protocols probably would be fine to go to the nearest ER, and then they would lateral after getting more supportive measures on board. It's a very good question and good thought in this situation.
So let's do some overlap here with the. We'll take that RSI. We'll take that RSI question there. So we're going to read this backwards because it's about the sympathomimetic overdose at the end. And so you're taking the airway of somebody who is a suspected sympathomimetic overdose. Agent of choice. They're asking, and is ketamine favored for that, or is the fact that it has some sympathetic effects of its own going to add? Should we try something else for that particular patient?
So that's a good question. And so this brings up a more important point, which is if somebody is revved up, whether it's because they are trying everything everything they possibly can do to prevent themselves from dying if they're in shock, or if they are revved up on a sympathomimetic from a bunch of cocaine, if you give them ketamine, while ketamine will increase the sympathetic surge slightly, the overwhelming effect will be to drop everything because you're sedating this person. So they're going to drop their blood pressure, heart rate, everything will go down, and then it'll go up a smidgen, but the net effect is down. So in this situation, I wouldn't overthink it. I would just use ketamine like any other patient. And then for post-intubation sedation, our protocol allows for ketamine, Q20 minutes, or Versed in this situation. And I would probably use Versed for post-intubation sedation for the exact reason that they asked that question.
And if we have a department, because we have both the lorazepam, the Ativan, and the midazolam in protocol, not every department has a refrigerator.
Correct.
So not every department carries the lorazepam. If they do, one versus the other.
They're
in
all
this case?
sufficient. In this case, most of these sympathomimetics will last longer than the Versed. I mean, for us in the ER, it's very easy for us to redose with more Versed depending on what the patient needs. But if you only have Ativan, Ativan is sufficient. Any benzo will work in this situation. And then for context, when I have a meth overdose, meth has a 20-plus hour half-life, so it lasts for a long time. I use Valium because I want something to last the duration
longer.
of the overdose. And so Valium is kind of the drug of choice for me when I have somebody who took a bunch of meth and needs something.
You have to dust it off and get the Valium out.
Yeah, Valium works quite well in that situation.
Now, we're not going to send this guy a grab bag because he may or may not be standing in the room with us. But what should EMS do if there's an overdose not in the protocol?
So a lot of the overdoses that we worry about will kind of overlap with something in the protocol. So I would recommend always getting an EKG. Any overdose, get an EKG. And if they have any of those columns, you can treat them in that column. But then if you are concerned, you have 2 options. Option number 1 is call poison control. Like they know that EMS will call them. Sometimes the family may have already initiated a phone call waiting for you, and they could give recommendations, or call med control and get advice from your friendly neighborhood med control physician. But I would say definitely still get an EKG, and while you're asking for help, treat them along those columns because you still won't go wrong. And if you give them something in the column, you're not going to hurt them. But failure to do so, if they were in that column, may hurt them.
Got it.
And like you said prior, usually an overdose is a poly overdose. It's several things. So if you start treatment of one and you see that you've started to fix something, maybe you're going to find something else. But this is exactly what you say.
Absolutely. And a lot of the recommendations that poison control gives has to do with how long we monitor them and some of the treatments that you don't have access to. But at least the stuff that you have access to, as long as you're doing that EKG and following the column that you think is appropriate, or columns, you're not going to go wrong.
I was just talking to the students the other day about this. I don't know if I told you about it or not, but if you've ever spent time on the phone with poison control, they're amazing.
Oh,
they're absolutely amazing, and they will walk you through everything. And it's not like calling to get your laptop repaired. It's pretty neat.
And at the very least, they may not give you an answer right away, but you're teeing it up for when they get to the hospital. You may call them and say, hey, this patient took X, Y, and Z. I got to go resuscitate them. But then when we call them in the hospital, we already have recommendations waiting for this patient because it's a government agency that communicates from county to county, so we could kind of get faster life-saving answers.
The other big change was hyperkalemia, and we added pages for specific to hyperkalemia. Historically, there was bits and pieces of the treatment of hyperkalemia, but it was specific only to missed dialysis, right? And missed dialysis should be number one.
Number one risk factor,
yeah,
absolutely.
exactly. But we missed a million other things that could be hyperkalemia. And again, we can identify this on our EKG. This is something we should pick up into and looking for.
The next most common is going to be any insult to the kidney, the most common being dehydration. So if somebody has profound diarrhea or vomiting or poor PO intake, or they have rhabdo from maybe lying on the ground for quite some time, and maybe a day or two, we would worry about hyperkalemia.
It's alphabetical, bro.
And just like with these overdoses, the way that we make the diagnosis is with EKG. So the first thing I ask for on any potential hyperkalemic patient is I want a quick 12 lead, because if we see some of these signs, we can then treat them.
The EKG changes that we're talking about in here, there's really kind of three things that we're traditionally taught, and you've touched on this already, is peak T waves, right?
Correct.
But I think that gets sold as like the gold standard.
And that's actually the least important. Like when I see peaked T waves, I'm like, this could be hyperkalemia, but that's not getting me worried yet, because actually the true answer is we don't really treat the peaked T waves. Like that's not high enough that we worry. We worry more about non-specific bradycardias or QRS widening or loss of the P wave. So the stereotypical thing, like if you take one thing away from hyperkalemia, it's if you see what is called a junctional bradycardia. You see a bradycardic rhythm with no P wave. That, to me, should be hyperkalemia until proven otherwise.
Pathogenic.
And you could still have another cause of it. It may not be it, but that's someone who I might empirically consider giving calcium to. And if they get better, then you've confirmed hyperkalemia. You've diagnosed it, because nothing else will get better with calcium.
So the other treatment for the spontaneously breathing patient is high dose albuterol. And I've had people discuss with me like, well, it's just albuterol. Yeah, we're giving a lot of it, but it's just albuterol. How can that really help? And there is some rather profound effect on potassium shift
Absolutely.
with albuterol alone. Speak to that a little bit, because I mean it's super important. It's a heavy lift, and I don't think that's grasped, because we use it so frequently, right?
Right. And
It's
so
ubiquitous.
there's two things we do in hyperkalemia treatment, right? The first thing is we want to stabilize the heart to prevent them from going into a potentially fatal arrhythmia. And that's what the calcium is for. It's stabilizing the myocardium. And then the second thing we do is, can we get potassium away from the heart, as in suck it into cells so the heart isn't exposed to it? And so one of those things is albuterol. And what we found is it can shift potassium into cells, and it can drop, I think one full treatment can drop it half a milliequivalent, which is a significant amount, which may be the difference between fatal arrhythmia and not. Well, that doesn't fix the issue, and it only lasts for maybe an hour or two. That's hopefully you guys aren't transporting patients for more than an hour or two, and that buys you enough time to get them to what they really need, which is something that will definitively get potassium out of their body, which might be getting them to pee more by resuscitating their kidneys, or if they're a dialysis patient, getting them emergent dialysis.
Dialyzed. Yeah. And then what's the role of the calcium in this particular? And hyperkalemia.
And so that's what stabilizes the myocardium and kind of that's why if you give albuterol, you're not going to see that sudden change in the rhythm strip from going from, let's say, a junctional bradycardia to a normal PQRST. But when you give the calcium, that, just like sodium bicarb with a sodium channel poison, will just suddenly change the EKG before your eyes, which is both life-saving and diagnostic, which is a very satisfying thing.
Back to your point, though, about the peak T waves, I can recall early in my career seeing peak T waves, what I thought was, and hey, doc, look what I found. They're like,
Doesn't mean
Yeah, and then I felt so depressed. But like you said, I mean, first of all, peak T waves are very peak T waves, and to be worrisome, they're very peaked. But again, that's not the first thing you're looking for.
And if you do see it, I mean, that should trigger you to think, maybe I should ask some questions. Have you been vomiting a whole bunch, having lots of diarrhea? They didn't bring that up because they were just calling for shortness of breath, but maybe something else was going on. And then you finally get to the bottom of it and are like, oh, geez, I think they really do have hyperkalemia. I need to be aggressive. In terms of peak T waves, if you think that it would be very uncomfortable to sit on that T wave, it's probably peaked. If it doesn't look that uncomfortable to sit on, then it's probably not peaked. That's kind of how I think about it.
Now, what if there's peak T waves only in parts of your 12 lead EKG?
Then
is that diagnostic?
That still can be hyperkalemia. So none of these findings are 100% diagnostic, but all of them together in the right clinical picture can be. And then when in doubt, I would say give them the calcium. If you think they have enough changes on their EKG or even a change that you're worried, give them the calcium in that situation. Just make sure you have a good line, because if calcium extravasates, it can really cause some major issues. People can lose arms. So you give the calcium through a finger IV. Ideally something proximal and big, but if you have a good line, it is almost harmless in that situation.
So stepping backwards just for a second, because I'm going to ask you a rhetorical question. If I'm on the phone with med control about something and you've given me information and now I'm on the phone with poison control and they contradict that or give me a different guidance, do they trump you or do you trump them?
The online physician is going to be the end all. I would tell the online physician poison control said something else, because the goal is to make sure that you're not misunderstanding the physician. And if something the physician says doesn't make sense, ask them in a nice way. Say, I hear you telling me to do this. I thought I should be doing this. Can we just make sure we're on the same page? And I mean, if anyone asks me that, I'm just going to say, thank you for double checking. I actually do want this, or no, you're right, we should do this instead, and just making sure everyone's on the same page, because we're all on team patient. The goal is high quality care for our patient. I don't care who's right. I just care that the patient gets the right care.
All right. Let's see. What else do we have up here?
There was a question earlier about monitoring DNR patients. And
why? Why? Wow.
So DNR patients don't necessarily, they're not hospice, and so DNR patients still would want other care, and we should ask them what care they do and do not want. But I think it's very reasonable to monitor a DNR patient, because just they may go into VTAC and want to be cardioverted. They just don't want CPR or intubation if they die. They want everything up to that. So we should ask them what they want, and then do whatever treatment they would want. But when in doubt, DNR just means cardiac arrest. We're done. Everything up until that point, we should do it, which includes cardiac monitoring, cardioversion, all that good stuff.
I think a lot of people get hung up on DNR means do not treat, and that's extremely frustrating, to your point, because people could change their minds. That patient could be alert and oriented ×4, and we could say, hey, we see this, or we see that you're having a STEMI and we want to give you some medications, or we see that I actually had a DNR patient in SVT, is one of my cases. And they want treated, right? They want treatment just like any other patient. But I think a lot of people unfortunately get hung up on, well, I just can't treat them. And that's not true. That's just extremely false.
Not a ride to the hospital.
As a quick aside, for hospice patients, they still deserve care also. Their goals of care is not life-saving. Their goals of care is, I want to be comfortable. If they're in pain, they still may call 911 because they may need extra analgesia, and we may need to transport them for that analgesia. They'll go home after that, but we want to make sure that they are comfortable. So even our hospice patients deserve aggressive care within the realm of what they are wanting to have done.
Now, we don't have the time to talk about it on this live show, but let's just hit some of these other questions up here, kind of grab bag of everything, because we also did a lot of restraint talk in part 2 of your series, and then of course RSI stuff in part 3 of your series. But let's just get these out of here. So we.
How do you decide which patient gets olanzapine versus B52 versus ketamine?
So Zyprexa, if I may, I think they're is a little bit of a misunderstanding, and Doc, you can correct me if I'm wrong, but Zyprexa is really geared towards that manic schizophrenic that just may not be on their medications.
Psychosis.
That, maybe they call and they want help and they're cooperative, and this is the way I usually teach it and talk about that question because we get it a lot. And I'm like, hey, that's for the patient that's going to call. They want help. They've been off their medications. Mainly it's for manic schizophrenics. And, they're very cooperative. They want to seek help. And for whatever reason, they don't have their medication anymore. That's the patient I choose to give Zyprexa to. When we get into when I want to use the B52, that's when they're a harm to themselves is the way I would look at that. And then ketamine, obviously they're an extreme harm to themselves and now me or others.
And I love the way Dr. Spanner put it. If you thought you were a cop and you wanted to use a taser, that's when we're medics and we use ketamine.
Yeah, I agree. That's a great way to put it. So am I off base with that, or is that fair?
That's a good way of looking at it. Zyprexa should not be the sedative for someone who is actively aggressive. This is someone who is calm. We're giving it as Zytus, or we're giving it in their mouth. You can't put something in their mouth if they're going to chop your finger. This is somebody who, if we fail to do this, maybe they would get aggressive 5, 10, 15 minutes down the road from some minor thing. And we're trying to get them squared away on something and get ahead of the curve. Exactly. Where ketamine is somebody who is acutely of risk to themselves, which is why we're doing it, but also a risk to you. I mean, if they're profoundly agitated, they look like the Hulk, they're throwing people left and right, they may be running out into the street, potentially going to get hit by a car, we need to control that situation, not only for us and our safety, but really for this patient's safety, because they could easily get hurt and or have a very bad thing happen, and we're trying to control that. And then in the middle is where we'd use other stuff. I almost never would recommend B52 in the field. I would say if you're somewhere in the middle, I would use IM Versed, because that's going to be much faster than Benadryl IM as well as Ativan IM, and you will probably get them controlled a lot faster. And then it also only lasts up to 2 hours, so it allows the hospital then to kind of reevaluate and see what they need, or if they need something else.
Yeah, perfect for our setting, delivering them to you.
Marco, why don't you give us that indications to see if rock has taken effect? So you've given your paralytic.
Yep.
How do we know the patient is truly and utterly paralyzed?
It takes about 30 seconds to a minute to get fully paralyzed, but you're not going to see the fasciculations that you see with sucks, because it's just a different type of agent. You're just going to see them suddenly not breathe anymore, or get hypoventilate, shallow breathe, and then be completely apneic. And then if you take a look and they still feel a little tight, you can bag them and wait maybe 20, 30 more seconds, and then take a look and they're going to be fully limp. But I would literally look at the clock when you push the med and say, I need to wait 30 seconds to 1 minute before I take a good look, if you want the greatest view. If they're hypoxic or having other issues like they're vomiting, you may not have that luxury. They only may be partially paralyzed when you get in there, but it kind of depends on the patient. For a very stable patient I'm intubating for airway protection, I wait the full minute because I just want that good look so that I can get the airway very quickly.
I think you spoke a lot about that when we talked to this on the original episode, but I thought that was a great point, that unless they're a high Malman-Patty score to begin with, if you're looking and you're having issues, it's probably not working yet. That's not the way it should be. It should be a nice, easy...
Don't rush it.
Right.
Don't rush it.
Yeah.
And then after a minute, if it still isn't working, I would be worried that maybe the line blew, and that all that medication is an IM injection instead of an intravenous injection. And sucks increases potassium, which is why we can't redose it safely, because it can cause some major issues. But rocuronium, if you give too much rocuronium, they're just paralyzed for longer, and that's okay in the field. We're going to get this airway one way or the other, and so in this case, we're allowed to redose at the same dose times 1. If it's not working, then we got to figure out something else, involve med control, get some additional orders, because something is not working if somehow the medication didn't work on 2 injections.
2 injections, right?
Yeah.
So
I get eyelashes.
Oh, that's a good idea. Yeah. If you touch their eyelashes and they're not having a standard kind of corneal response or corneal reflex, then that's actually a good way.
all right, we want to do one more and wrap it up, because we're coming right up on an hour here. And hey, folks, we really appreciate you jumping in here. These are the most questions we've gotten so far. It's fabulous that you're getting in here.
They're actually good questions.
Amazingly good questions. No, this is great stuff. Let's see. Oh, here, let's do one more RSI. Give me that. What's the most important thing medics can do when preparing for field RSI? One more up.
Oh, that's great. This was a huge
Yeah.
discussion.
Oh,
We
yes.
talked about
Yeah.
Right.
transition,
We-
checklist,
exactly.
preparing.
We
Yeah.
Spend a lot of time on it.
Yes. Use the checklist.
All right,
The checklist
we need the
is-
35-second version of it, though.
The checklist is there for a reason. It lists all the things that you potentially would need and hopefully don't even need. But you want to cross T's and dot I's before you push those meds to make sure that everything is set up and making sure that everyone's on the same page. If you prepare for everything, then when something happens, you're going to be ready for it.
Hurry up and take your time.
Yep, exactly.
Yeah.
And yeah, because you're intubating people the majority of the times in cardiac arrest where you're just moving quick because you have so much to do. But with RSI, as you said, take your time.
Shift.
Everyone's gonna be on the same page, and then when you're ready to push meds, everyone's confident that they have a plan in place and have your backup ready in case the first line
This
fails.
airway is on your time.
Right.
So your first attempt is your best attempt.
I like that. Yeah. Airways on your time.
You can put that on a T-shirt if you want.
Why did John dive out of the room all of a sudden? He knew we were gonna. Oh, actually, the audience hasn't seen next Monday's episode yet, so you got to tune into that of us busting Dr. Hill's chops about his was his doctor words.
Doctor.
Doctor words. Those are doctor words.
Doctor words.
So he can clue us into all different doctor words. So this. Again, thank you all for these fantastic questions. Thank you for tuning in. Whatever platform you decide to join us on. This month, turns out there's 5 Mondays, and in a panic about 2-3 weeks ago, we were like, oh no, what are we going to do on the 5th Monday? So we've got some bonus material, just a standalone episode for you on Memorial Day. So again, that's next Monday.
Yep.
Yesterday actually started EMS week, so happy EMS week! You can start your EMS week out with a kick-ass podcast, and thank you, thank you for joining in, or if you're watching this after the fact. And the other plug we gotta sail in here is part of this podcast has really prompted us to do a lot of back end work on the pre-hospital paradigm in general, which is just all things EMS education and FOAM, open access education. And the prehospitalparadigm.com has really started to come into its own. There's more things there than just our podcast. If you do click on the podcast, there's all the show notes. There's other links. There's some humorous images of us being goofy during the episodes. But then also all the medical director messages, all of the Pharmacy Fridays. We got our TACMed guys. We're really trying to use that as the umbrella, that prehospitalparadigm.com, as the umbrella for all of this open access medical.
Great resource website.
Yeah,
too.
no,
It is.
it's really coming into its own. I'm excited to be packing that with information. We got a bunch of cool other stuff lined up that's coming in behind that. So keep checking back. I think that's only going to get better here over the next next couple of months as we're bringing in a bunch of other contributors, right? So it's just not the 4 of us throwing stuff at you anymore. Now it's a bunch of other people from the Institute, and of course, shameless plug to follow us on YouTube and like us on Facebook, and hopefully we'll thank you for letting us hijack your Monday, and we'll talk to you soon. Appreciate it. Thank you.
Thanks.
Thanks, guys.
I had no idea.